When I started my practice in primary care at Mount Auburn, after practicing in Europe and Israel, my home country, and a senior... So when I started my practice in primary care at Mount Auburn, after practicing in Europe and Israel, my home country, a senior colleague of mine advised me to perform as many procedures as possible in order to gain a good contract with our employer. When I expressed my surprise that this might include unnecessary tests, his reaction was, well, I see it this way. Either you're playing the game and survive, or you think you can change the system and don't. So I assume I belong to the second type, a primary care physician and a hospitalist at times who think that she can change the system. Throughout the years as a clinician in the US, I got to know closely the culture of overuse that my colleague referred to. There's a business aspect to medicine, and it's not always in favor of our patients. I had many similar conversations and experiences like the one that I had before. And finally, in the summer of 2012, I decided to take a leave of absence for my practice and to pursue a master's degree in public administration at the Harvard Kennedy School. I wanted to see if I can acquire the tools and the skills to make a difference. During the winter break, as a student at the Kennedy School, I went back to moonlight as a hospitalist at Mount Auburn in the step-down unit. By then, I didn't see patients for 6 months. There must be something about the time I was away from taking care of patients, because when I saw again how we treat these elderly, fragile people, I thought to myself that something has to change. Why do we do that? Why do we connect all these elderly people to so many wires and lines and tubes? And most importantly, do the patients truly want that? I wanted to see if this is a unique demographic problem of Mount Auburn, but realized that on average, 50% of the intensive care unit beds are occupied with people above 80 years old. My patients list, my Christmas list for that holiday coverage included 13 patients. 9 of them were above 80 years old. 5 of them with metastatic disease, and 3 of them with advanced dementia. I had only 1 patient at this age that didn't have a terminal illness background. All 9 patients did have a short conversation about the care that they are going to get with the caring team when they were admitted to the step-down unit. But 6 of them, including their family members, didn't remember the content of the conversations and didn't understand why they're getting an intense care. I was stumbled by this news. Is this what end of life should look like? The fact that we know how to treat, does it mean we need to do it until the last days of life? I knew that we doctors have a hard time to stop doing what we are trained to do, which is to treat. And I wish it would have been easier for us at times to switch from doing to being. But I decided at that moment to concentrate on the patient's aspect, to see if we can help patients early enough before they become terminally ill, to think about their values and beliefs around end-of-life care. I looked into data and realized that actually the problem was much bigger than what I thought. 9 out of 10 American people would like to have the conversation, but only 1 out of 10 had a conversation about end of life with a healthcare provider. 70% of people want to die at home, but 70% die in institutions. And the financial burden, 62% of bankruptcies are related to healthcare expenses, where the leading cause is end-of-life care. And on a national level, more than a third of Medicare expenses are related to end-of-life care. I knew that I needed a unique and innovative mindset in order to deal with this data. So as I mentioned before, I thought that we need to start early enough the conversations. I was also aware of the struggle between specialists and primary care physicians where nobody wanted to be the angel of death. I did think, though, that their responsibility lies within the primary care setting, since they have the ongoing long-term relationship with patients and their families. It seemed logical to me that patients and families will conduct these conversations, and I, as the healthcare provider, will be there to listen and to answer questions. It was not about me telling them what to do. It was about them exploring what they would like to happen when time comes. It's with this framework that I built my pilot project for the innovation program. My team and I had conducted so far 4 group discussions. We had 15 patients above 70 years old with their family members that went through these discussion groups. And the control group, we had 11 patients that didn't participate in the discussion groups. The sessions start with a video of a typical American family that conveys the end-of-life discussion with the grandfather. The video raises many personal stories among the participants. Then, we give to each patient a values page that was adapted from the Conversation Project. This is a nonprofit that is dedicated to help people to talk about their wishes around end of life. In this value page, the patients rank their wishes around end of life issues. They do it with the family members if they had one to bring with them. And we conclude the session with a brief explanation about healthcare proxy and GNR-DNI forms. Patients tend to be very open in these discussions and have commented that having the discussion in a group gives them the ability to learn from others' experiences and validate their own thoughts and beliefs around end of life. It seemed that most of them realized that the most peaceful deaths were the ones that were planned out in advance. We didn't sense a fear of dealing with death, but rather a wish not to be in pain, not to be a burden on families, and to be surrounded by loved ones. Family members also expressed relief. A daughter of one of my patients said, "Thank you for doing this. When my father died a few years ago, I didn't feel comfortable to make decisions on his behalf because I never knew what he would have wished for himself. But now, after going through that with my mother, I think that I will feel less guilty." And even matchmaking occurred in one of the group discussions. An 82-year-old patient of mine came to me after the group discussion and told me, "I met this old little lady in your group and took her phone number. And I have been driving her grocery shopping ever since." We realized that there was an increase in 40% of the signed healthcare proxies after participating in this group discussion. We also quantified the amount of discussions that each patient had with other people outside of the group. And on average, each patient spoke to 4 other people. 4 times 15 patients that participated so far makes 60. 60 people were touched by these only 4 group discussions. Our plan for next year is to expand the model to other providers, that they will expose their own patients to this kind of group discussions. We would like to train retired physicians because we think that their vast experience will make them the perfect match for this important role. This Christmas, I'm going to work at the step-down unit again. And I have this feeling of satisfaction because the process has begun. I do invite you all, the medical community, to join us to help patients and families to explore their own wishes and values around end-of-life care. Thank you.